comes the monitoring of, I am saying IUI cycles because IVF it is different. And monitoring, I am talking of transvaginal sonography, preferably done by yourself, not by radiologist, because they really don't know and they cannot correlate it clinically. So what we are looking, you are looking for the number and size of follicles and the pattern and thickness of endometrium. So basically when you are calling her, you are looking for number of follicles, size of follicles. Gradually you are monitoring the development of that follicle up to the dominant follicle. Simultaneously endometrial lining, you are documenting ovulation, and of course you are looking for any coexisting pathology in the uterus and ovaries. So first and foremost you should start the baseline scan, that is day 2 or day 3 by yourself. Then how frequently you should call this patient? Don't call them too frequently. Early follicular phase, if it is oral ovulogen, you can call them directly on day 9 or day 10. For gonadotrophins, I have told you day 7 or day 9. And then depending on, see, follicle develops 2 millimeter per day on an average. So you can count कि आज फॉलिकल का साइज 10 मिलीमीटर है तो उसको 3 दिन बुलाने का जरूरत नहीं है, क्योंकि 3 दिन के पहले तो वो 16 मिलीमीटर नहीं होने वाला है. So call her after 3 days. But yes, if it is 16 millimeter and she is on gonadotrophins, then you have to of course call her daily. But if it is 16 millimeter and she is oral ovulogens, call her after 2 days. So this is how you have to individualize. So basically oral ovulogen, baseline, in between egg, and just trigger. So 3 suffices. Gonadotrophins 4, maximum 5. There is no need to call her daily for the follicular monitoring or even for calling her alternate day monitoring. Now, if a follicle is mature, that is 16 to 18 millimeter, it will have thin walls. It will have regular round shape with no echogenicity in the lumen, and it will show a thin hypoechoic rim surrounding the follicle. This hypoechoic rim and the cumulus-like shadow, this develops approximately 36 hours before rupture, that is ovulation. Whenever you are counseling your patients, हम बहुत roughly बोल देते हैं इतने अंडे हैं, इतने अंडे हैं, इतने अंडे हैं, और पेशेंट वो बात को पकड़ लेता है. सो वी हैव टू टेल देम कि ये अंडे नहीं हैं. आई गिव देम एन एग्जांपल ऑफ ग्रेप्स. भैया हम जो मॉनिटर कर रहे हैं वो ग्रेप्स जैसा है. ग्रेप्स का हमको समझता नहीं है बाहर से कि उसमें बीज है कि नहीं है. वैसा हम जो मॉनिटर कर रहे हैं वो फॉलिकल है. सोनोग्राफी पे हमको नेकेड आई से बीज यानी एग नहीं दिखता है. So you have to be very clear, and now I have specifically started using the term जब से AI आया है follicle. I never use the word egg. पहले मैं भी अंडा अंडा एग एग करते रहते थे. तो अभी हम follicle, number of follicle, size of follicle, तो उनको ये क्लियर करें. ठीक है. Ovulation, how you will find out? Suddenly it will collapse, the margin will become irregular, and there will be fluid in OPD. So you know that this has ruptured. Now there is an emerging role of Doppler in follicular monitoring apart from our routine TVS. So these are the Doppler indices that a mature follicle will show vascularity in at least 3/4 of the follicular circumference. PSV will be 10 centimeter per second. At this time the LSR starts, and this is the right time to give SCG trigger. This is the study which is published, I think, recently in 2024. This was a prospective study for the role of color Doppler in IUI cycle monitoring. Of course, they have divided these follicles into grade 4, 1, 2, 3, 4. And grade 1 में 25%, 50%, grade 3, 50 to 75%. And grade 4 में blood flow will be visible in the 100%, 75 to 100% of the follicular circumference. So it's quite obvious and logical कि grade 3 and 4 are good follicles. Similarly, endometrium का भी है. Endometrium also we know that grade B, and grade C. So you all can see grade 1, this is the most sought after. क्योंकि this is grade 1, grade A, where we have having triple line endometrium. Grade B is moderate, चल जाता है, हम कैंसल नहीं करते हैं, बट ग्रेड C हमें नहीं चाहिए होता है बिकॉज वी नो कि चांसेस आर लेस. As follicles is studied by color Doppler, similarly endometrium also you can do color Doppler, and this is also divided into zone 1, 2, 3 and 4. Again same way, zone 1 it is seen at endometrio-myometrial junction. Zone 2 the vessels penetrate through the endometrial edge. Zone 3 it reaches the intervening hypoechoic zone, and zone 4 they reach the endometrial cavity. So it is quite obvious कि कौन सा endometrium अच्छा है. So if you want to use color Doppler, हर machine में color Doppler होता है. You can just run the color Doppler and you can see follicle में भी कितना circumference है and endometrium में भी blood flow कौन से zone में है. But apart from whatever, thickness matters. It is the thickness we all are interested in. तो कितना thickness होना चाहिए? 9 to 14 millimeter. Of course, we don't cancel our cycles when it is 6 millimeter also. So cut off if you are asking up to 6 millimeter, even I have gone ahead and done the IUI. 14 millimeter से ज़्यादा भी हमको नहीं चाहिए है because that is not a good endometrium. So हमारा target है 9 to 14 millimeter. So this is the summary when you are doing follicular monitoring. The size should be around 16 to 18. But for oral ovulagens 20 to 22 millimeter, endometrium 8 to 10 millimeter. Follicle का morphology thin wall, no internal echos. Endometrium का morphology grade A or grade B. Vascularity of the follicle 3/4 of the circumference होना चाहिए और endometrium में zone 3 to 4 होना चाहिए. If you are doing color Doppler, तो आ रहा है 0.4 to 0.48 for the follicle, and for endometrium it should be less than 0.5. Uterine artery PI अगर कर रहे हो तो endometrium का less than 3.2. So this is overall as far as the monitoring of this cycle of IUI cycles on transvaginal ultrasound. Any questions as far as the monitoring is concerned? I have told you when to call, the frequency, what you are looking for, the normal things, and also the color Doppler.